Good morning. First of all, I'd like to thank for the wonderful opportunity. I'll be speaking on reading corneal topography because we use wavelet localizer. Talk will be upon the wavelet localizer. So a pentagon has basically five functions, which is a Scheimpflug image, the topography, the anterior chamber reconstruction, corneal thickness, and lens densitometer. So in a typical wavelet oculizer printout, we see the patient details on the left top corner, the Q value and keratometry, the Pachy and AC parameters, and then the quad maps. We'll go through one by one. So first of all, in the patient details, you have the name, the ID, the date of birth, which is important because keratoconus is more common in younger age and pellucid marginal degeneration is more common in older ages, and the examination date, which is useful for further cross-reference. The corneal parameters, you go through the quality of the scan, which should be okay. In case there are data grabs, blinking, fix or model, it is unreliable because it has a lot of extrapolated data, which is common in advanced diseases. Next, we have the keratometry value. It is the value from the central 3 mm of the cornea. The K1 is the flat keratometry, K2 is the steep keratometry, Km is the mean K, R is the radius of curvature, astigmatism is the mean measured astigmatism, and the axis is the axis of the astigmatism. The total corneal astigmatism is calculated after excluding the posterior corneal astigmatism from the anterior, and it is the compare the measured and manifest astigmatism to exclude lenticular astigmatism, tear film disturbance, PSCC, and R per is the radius of curvature. Pachymetry, the pupil center is the pachymetry at the center of the pupil. Pachyapex is at the apex of the cornea, and the thinnest location is at the point at which it is thinnest. More than 500 micrometers is normal, 450 to 500 is suspicious, and less than 450 there is more chances of ectasia, and difference of more than 10 micron between apex and the thinnest location is considered significant. Next to the anterior chamber volume, with less than 100 it's better to rule out ankle closure glaucoma. Anterior chamber depth of more than 2.8 is important for isocial implantation. The keratometric power deviation should be less than 0.75 and the angle of less than 25 is considered shallow. The pupil size is the mesopic pupil. And next, moving on to the axial and sagittal curvature, the pachymetry map and axial curvature map. Green coding is considered normal, yellow and blue should be viewed with caution, and red is abnormal. Next to the anterior and posterior elevation map, it is calculated from the 9 mm zone. Red and yellow are above the best fit sphere, green is along the best fit sphere, and blue is below the best fit sphere. And anterior elevation more than 15 is considered as keratoconus, and posterior elevation more than 20 is considered as keratoconus. Next, we go on to the Bellin-Ambrosio enhanced ectasia maps. The left side shows the ectasia maps, and on the right we have the progression index, the CTSP, and the PSI mapping. With the elevation map, the radius of curvature of the best fit sphere and diameter zone which is used to compute the best fit spheres noted. Elevation exclusion map, the central 3 to 4 millimeter area of the cornea around the thinnest point is excluded to calculate the best fit sphere. In the 8 millimeter zone, the anterior elevation more than 8 and posterior elevation more than 16 is considered as significant. And this is the difference in elevation. Here, more than 12 is considered as ectasia, and posterior elevation more than 20 is considered as ectasia. The progression index, the normal value is less than 1.2, maximum should be less than 1.5, and index of more than 1.8 is considered as keratoconus. The CTSP and the PSI curvatures is based on the population reference data. The two lines above and below the central line signifies the 95% confidence interval. A sharp drop before the 6 millimeter zone signifies ectasia. And the curvature of the map, if it's S-shaped, it can mean keratoconus. Inverted S-shape is pellucid marginal degeneration, and flat is corneal edema or fuchs. The D values, the white is considered normal, anything red is abnormal, and the final D is the overall values taking others into consideration. And this is the comparison map where we can compare at least 2 maps, and usually we can compare up to 4 maps. An increase of more than 0.5 diopter or more in the steepest meridian between 2 sagittal curves, and a decrease in more than 10% of corneal thickness at the thinnest point is considered significant. The superior inferior values, the inferior steepening more than 1.1, and in formiferous keratoconus 1.4 to 3, and in keratoconus it's considered more than 3. In skewing, more than 22 is considered as abnormal. So we have a few examples over here. The Q values over here is normal, and then the K readings are in the normal range. The pachymetry is normal, and there is a symmetric bow tie appearance. The Bellin-Ambrosio curve is normal, so this is a normal study. In this patient, you can see the Q scan is normal. The K readings are on the higher side. The K2 is 48.8. The pachymetry is normal. Here you can see a symmetric bow tie pattern. And the Bellin-Ambrosio curve, the front elevation is higher, and the rest of the readings are normal. And all the parameters are in yellow color. So we have to view it in caution and rule out keratoconus. And this is a case of against the rule astigmatism. This is a case of keratoconus where the K readings are normal, and you can see an inferior steepening with thinning of the cornea and corresponding elevation in the anterior and posterior flow. And in the Bellin-Ambrosio, there is a yellow and red coloration, and the progression index and the CTSPI and the progression indexes are all normal. This is a case of advanced keratoconus, where again you find everything in red, and the corneal thickness is less, and with corresponding anterior and posterior elevation. This is a case of pellucid marginal degeneration, where you can see a lobster claw appearance with a corresponding thinning and the elevation. This is the other eye of the same patient showing advanced disease. So my 10 commandments would be to check the would be to do a clinical examination and correlate. QS should be okay. K reading more than 48 is considered as viewed with caution. Pachymetry reading should be noted. Beware of reds in quad map. Check corresponding points in the thinnest pachy, highest point in elevation. Bellin-Ambrosia, red is ectasia. A progression index of more than 1.81 signifies keratoconus. CTSP and PSA sharp drop before 6 millimeters keratoconus, and D value should be noted for keratoconus. Thank you.
So, Dr. Niranjana, if I may ask you, for the benefit of our postgraduates and early practitioners, so what are the kind of topography that you would absolutely not touch? What kind of cornea will you absolutely not go for laser vision correction?
Yeah, so basically when there is an advanced keratoconus and there is a very significant refractive error where it's not possible, and if the higher order aberration is more in keratoconus or something, we don't touch it. So if it's mild to moderate, we do go for trans-PRK with C3R, and keratoglobus we don't touch, and pellucid marginal degeneration we don't touch because the ectasia is inferior, so it's difficult to manage.
Basically, anything indicative of ectasia should be excluded.
Yeah.
Absolutely.